into this, there's barely little to nothing that we do with the GI system. Can anybody tell me why?
Gas.
Yeah. So this isn't going to be a very hard section. There are some things that you need to know. Like the image that I saw 2 weeks ago, and I was like, what the hell is going on? I have no idea. And then the rash made me feel stupid, and I was like, oh, that's the stomach. Yeah. So I'm going to show you images that weren't shown to me so that that won't happen to you, okay? And then I'm just going to walk you guys through kind of what is important. What does ultrasound have to do with the GI system? And normally it's a pediatric thing and not an adult thing, just to be really honest with you. And unless you work in a pediatric place, you don't need to know some of this stuff, okay? So you know me, I'll let you know what you need to know. So let's start with so we're going to talk about the esophagus, then the stomach, then the small intestine, and then your large bowel, okay? And of course, images, I gave you guys lots of images. So the esophagus, it is going to start at the mouth, and it ends at the esophageal sphincter. As you can see, what is a sphincter, by the way?
Suckle muscle.
Kind of like your, can I say it?
Yes.
Anus.
Yeah, like your butthole, your anal. Yeah, I just having fun. I'm ADD officially, so. But yes, it's, you don't want things to ooze out all day, right? So you need the sphincter to be able to open and close, open and close. So keep that stuff in. Important for us to know, because we're going to talk, we're going to bring this together, okay? So the esophagus starts at the mouth, flows down to the what we call the GE junction, where it terminates at the stomach. Now, this next paragraph is super important because nobody told me this, mainly Leah, blame Leah, and so this was really important when I went out there, and people were calling things different names. I had no idea that the cardiac sphincter is the same thing as the lower esophageal sphincter, or the esophageal sphincter, or the gastroesophageal junction.
Gotcha.
All the same thing. So I put it on one page with a little star for you guys, because you're going to hear all of it. So the GE junction really means gastroesophageal sphincter, or junction. And it is the same thing as the cardiac. And the reason why, show you some pictures here. So we start at the mouth, right? Oh, look, food going down. Oh, what's happening here? Oh, they have an esophagus like me, man. Esophagitis. Inflammation, and food gets stuck. By the way, you don't need to know that.
That sucks.
But that's what's happening. And then we've got food peristalsis going down. And then here is lower esophageal sphincter, LES, or we call it the GE junction, which is the gastroesophageal junction. It is also called the cardiac sphincter. The reason why it's the cardiac sphincter is because guess where it is? Right by the heart. Yeah. Is this crucial for you to know? You need to be aware of the term and what it is, because when you scan, you can actually see it. And what I don't want you guys to do is make a mistake and call it a mass. That is the only thing we use it for ultrasound for. Okay? Here's what it looks like. This is what your thyroid looks like, by the way. This is thyroid tissue, left thyroid tissue. This is the esophagus, or the esophagus. This is the trachea. Here is the esophagus. So when you guys, and you don't have to memorize this right now, we're not talking about thyroids. I just want you to know that eventually when you scan the thyroid, you're going to find the esophagus. It's always going to be the left portion of the thyroid. Don't think it's a mass.
And it kind of travels posterior to the trachea and then
It does.
goes lateral left?
Yep.
Okay.
Goes posterior. Yep.
And thyroid, can you show it again? Is it the whole?
Oh, yeah. Thyroid is this tissue right here. Yeah, it's this little tissue. And this trachea. This
Does that thyroid have a colloid cyst above there?
Yeah,
Uh-huh.
Cool.
show off.
Yeah.
But yes. And it's too small to measure.
Ah.
How's that? I love it. You guys are great. You guys make it easy for me to get all that. I'm like, can I just get paid to teach? Literally, it's too much fun. Okay. Then, on a sagittal image, this is, how do I know this is a sagittal image?
Elongated.
Aorta. Here's your aorta. What's this?
That's me.
What's this? Know it because it's gonna show up on your board. Good job. Oh my gosh, what is this? Is this a mass?
GE.
Yes, what I just told you.
Cardiac sphincter.
Cardiac sphincter, GE junction, whatever you wanna call it, all those many names, the LES. It is, you can literally see it right here. So don't think that there's a mass hanging off of the aorta. And it's always gonna be the proximal aorta. Why would it be proximal and not mid? The cardiac sphincter, where's the heart? Yeah. And we're like, literally the aorta is coming out of the heart, like right here. Does that make sense? And that's why it's also called the cardiac sphincter. So, it starts in the mouth, goes down, passes through the thyroid posteriorly. So you're gonna see it in the thyroid. And it's kind of medial posterior. And then you're gonna see it posterior to the left liver lobe, anterior to the aorta proximal. This is what you need to know. Alright? And, alright, before I move on to the stomach, are we good? Good. Okay. I may give you pictures later, maybe on the lecture next week, and you might have to tell me what it is. I think you guys have gotten it though. Alright, our stomach. The stomach begins at the GE junction. What else do we call it?
A lower esophageal.
Cardiac sphincter or
LES.
LES, right? I just named like 6 of them. Call it which one. Alright. GE junction is used the most, and then LES is used, and then cardiac sphincter. That's kind of the. So, stomach begins at this junction, which is right here, terminates at the pyloric sphincter. And what is this? Oh, it's already labeled.
Duodenum.
Yeah, duodenum. You're so smart. Yes, the duodenum.
We can wait.
And so we have a sphincter right here. Why would they put one here? You don't want the stomach just leaking stuff out like poo. Right now, we don't. So the sphincter is what's gonna expand and contract, and it allows food to go in and out, in and out. What also gets dropped right here into the duodenum from 2 other organs?
OG.
Bile,
Pancreatic enzymes.
and then all of your juices from the pancreas, yes, which are enzymes, right?
Yeah.
Amylase, breaks up carbs, lipase, fat, you got it. Alright. Stomach, mostly found in the left upper quadrant. Does that matter to us though? Are we scanning the stomach? No. But, okay, sure. I put this in here because it was in Shay's lecture. The stomach though is anterior, since this is cross-sectional, you need to know where it's at, right? So it's anterior to the pancreas, spleen, and left kidney. Okay, that's cool. So the stomach goes first and the other organs layer behind it. That's cool. In the left side. It is inferior surface. The inferior surface rests on the spleen, left adrenal gland, and pancreas. They are not going to ask you this on boards, and I pretty much guarantee you're not going to be asked this on any of your tests. You do need to understand the concept though and the location. Why? When you're scanning like I did 2 weeks ago, you could have actually thought everything through and went, oh, that's the stomach. But did I? No. So now you know. The inferior aspect of the stomach lies more medial than its body. But, okay, cool. The stomach. Remember this picture when we learned the liver? We popped that liver right over here. Well, now we know the stomach. stomach is more over here on this side. And the stomach is gonna rest right in that little pocket, just like the liver. So it's gonna be anterior, which is here, but superior, and the posterior surface of the stomach located adjacent to the diaphragm. That sounds all confusing. What is that really saying? It's just going right up into this little socket here. The anterior part of it's gonna be here, superior part's gonna hit here, and the posterior part of the stomach's gonna hit here. And if I would have thought about this again, I would have been able to look at the echogenic diaphragm, and that would have given me a big clue that that was a stomach and not some big crazy weird mass. Especially because it was peristalsis. Like, hello. The way to learn is to make a mistake. So the stomach, sonographically seen lateral left to the left liver lobe in transverse left liver lobe images, and anterior to the pancreas region. Why am I even showing you these images? Well, you gotta know this, because I remember the first day I walked in here and you guys were just scanning for fun, and you're like, wait, this is so much fun, what is that? Oh my gosh, Connor's got a mass! Mass hanging off his left, I don't know if it's even in the left lobe of the liver. And I came over, I was like, oh, that's the stomach. And that is why you need to know this information right here. Do not be the sonographer who calls the stomach a mass. But you're cute when you're new, and that is okay. So, again, your aorta here, that left lobe of the liver, and well, we don't want to talk about that, so we'll wait. But this is the transverse cut, because it runs through the body transverse. So you're actually cutting it like a pipe. So you'll see it. And sometimes if there's stuff in there, you'll see like the gas and see it moving in peristalsis, and it looks crazy. Yeah. But sometimes it'll piss you off because then you can't see what you're trying to look for, like pancreas. It creates a heck of a doozy. That is why we have people NPO, no food or drink for 8 hours, 6 to 8 hours. Because we don't want to see that peristalsis, because that gas, it's going to gas out, and now we can't see the pancreas, we can't see the CBD, we can't see part of this, part of that, right? It just becomes pain and the,
Is that arrow on the left image going to the stomach? Or
Yeah.
Is that, okay.
This is the stomach right here, so yeah, label that stomach.
Does that show up like really bright? Like I think
You
I
also
saw
like,
that
you're like, I
before,
think I
and
saw
I
it.
was like, what is that? It's like really bright.
It's so
gurgling.
cute, yeah, when you guys find it for the first time, it's adorable. I chuckle inside, and go, oh, because you haven't had this lecture. So again, you don't have to know much about the stomach, you just have to know it's not a mass when you see it, because you need to know the location of it. And they call it the antrum, I guess, another term for it, and the lining, but I just wanted you guys to kind of see. Okay, any questions about that?
Well,
Alright, and the stomach. Seeing the left lateral, left lobe of the liver, and blah 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 image, we already said that. So here's your liver again. Here's this, you see this? This is what you're talking about, right? All that like, what is that? It's gas. You like me now? I did that last night. I was like, yeah. I started like, it was like too scientific, and then I was like, I'm just putting a gas sign. So guess what? You've also seen it here. Have you seen this?
Yeah.
That's just gas. Nothing we can do about it. If it's gassing, it's gassing. We do the best we can, and we do a representative image. Yes, Mr. Connor?
The last slide's stomach was kind of easier to see, not as much gas going on in it. Is that an NPO stomach, or would that just
It's
be?
pretty much MG.
Yeah, okay. Because I usually see a lot more gas.
Which is what we want.
Yeah.
Because when you do a AAA,
Yeah,
if this was all gassed out, guess what?
no mid.
Oh
You're
my
like-
gosh, that makes so much sense
Right?
now.
Yes!
Like, cool.
That's why then you're like, oh, I have to be so creative because I can't get it where I I normally get it, and then as a new person, you like freak out, right? Trust me, you can get it, you just have to work around the gas. Yeah. I have a partner, and be like, oh, I'm sorry, I'm just gonna do the gas. I'll give you a massage real quick.
We don't need to be NPO tomorrow for the.
Oh, you should be NPO, yes, tomorrow, because we're gonna do the AAAs. Yeah, because your midterm, which you haven't had yet in lab, is to do AAA protocol, and you have 20 minutes. So tomorrow we're gonna do mock ones. Tomorrow's where you can screw up and ask as many questions as you want.
And since you moved the AAA, does that mean right upper quadrant also moves?
Probably.
Did you say the,
I'm sorry. Sorry, hold on. Haley first and then Connor.
So is there 20 minutes of scanning, or is it 20 minutes of scanning and a rad report? How much time do we have?
I think
Is- so is it
35 overall.
Cumulative?
I think you have 5 minutes for your rad report, 15 minutes for scanning.
not the first one,
I don't remember, Connor.
not the first one, she has a cheat sheet
There's right
on
there.
the,
Oh, okay.
computer.
There's a cheat sheet around here. Can anybody answer Haley's question that I don't have the
I
answer?
think it's 20 for scanning and 15 for the rad report. I think the very first one she
Okay.
gave us
Oh,
tons
that's
of time.
pretty good, okay.
Yeah.
Yeah, okay.
But will we be able to do, will we be able to do right upper quadrant next week?
I don't know. Don't worry about that though. Just focus on what we're doing, and because if she has to push stuff out, she'll push it out, you guys.
Because
She's
it's
been very
supposed to
fair,
be-
hasn't she?
Yeah.
But so the AAA is gonna be ungraded practice.
Ungraded practice.
Okay, and then,
But I will know.
yes. Are we going, you said the midterm will be the AAA, or, so then we are going to get graded on the AAA? Okay, and that's why we're not learning the gallbladder
Yeah,
tomorrow?
she told me she just wanted to focus on the spleen and AAA, so I was like,
Okay.
I got this.
Yeah, because we were confused, why aren't you teaching us gallbladder for the right upper quadrant that's coming up, and now
Oh,
it
you
makes
guys
more
haven't learned
sense.
the gallbladder yet?
No.
Or pancreas.
Only liver.
Or pancreas?
We've only learned liver, main portal vein, and triple A.
Yeah.
Okay, that's okay.
She tells.
Especially when there's no
Don't
sphincter.
freak out. She knows that. She's not gonna
Good
ever have
joke.
you guys be graded on something she hasn't taught you.
Yeah,
Now, I'm very happy to overwhelm you and teach it to you really quick. And we can spend time tomorrow or even after class today learning one or two of those things. And then when she does teach it to you, you guys will pick up on it faster and she'll be like, whoa.
How'd you get so
Yeah.
good?
Huh?
How'd you guys get so good?
Yeah,
Oh my
exactly.
God. Oh.
Yeah. And then come in on open lab and scan. The only way you're gonna get good is by scanning and making mistakes. Yeah. So, happy to stick around and help you with all of that.
cool.
That'll be fun. Okay, so, we all know that this is gas? Okay, you do not need to know this, I put this in here. In the future, should you work for Seattle Children's or Mary Bridge, you will need to know this. So I'm just showing you images, not to overwhelm you. Don't study this, just know it's there. I wish I would have had this. I did work at Children's for a small part of time, because I volunteer there. I've been a volunteer since 2014. In fact, I'm going this weekend. Yay! Nobody really taught me this stuff, so just so you have it. Pyloric sphincter, as you guys know, is the end of the stomach, right? Where the stomach, well, this is the normal anatomy of the stomach. This is what we call a stenosis. A stenosis, just like a stenosis in the vessel, means what?
Narrowing.
Yeah, a narrowing. You got it. And so that can happen to a baby. So this is not an adult thing. You'll never look at it in an adult. But babies, brand new babies who can't keep their formula down and they constantly throw up, that means that this sphincter is not working. What goes in must come out. Yeah. So they bring their baby in and they're freaking out. They're like, oh my gosh, and then the baby gets malnutrition, right? Not good, not good, not good, not good. So what they have you do if you're a pediatric ultrasound tech, you're going to look at the sphincter and make sure that there's flow. Because what happens is the muscle just gets too thick. A sphincter, right, as you said, expands and contracts, but if that muscle is thick, it's not leaving any room for it to expand. And so they go in and basically get rid of that extra muscle. So I just wanted you guys to have some images.
Mhm.
And this is what it looks like. This is way too thick here. Nothing's going through. And this is what I saw, by the way. This
Cool.
is why I gave you guys this image. This is the stomach.
Yeah.
But it was over by the spleen, and I was just like, what is this?
It's like a star sky.
Brr. You guys probably would have done a better job than me, but some days, you know, just wait on the wrong side of the bed. But again, you guys will not be tested on this. Here it is again. What it looks like. All right, small bowel. You've got three parts to it: the duodenum, the jejunum, and the ileum. Small intestine. This is how it kind of curves. By the way, these are the major curves. And I think Shay has you guys draw it out in her lecture. And I'll show you what that looks like when we open her lecture. It's something I didn't pull into this. But the duodenum, most important thing about the duodenum is what you guys already know. We've got some amylase and lipase going in there. We've got some bile going in there. We just need to make sure that it's open, there's no obstruction, things like that. Jejunum, we don't really get to see it. Again, unless it's pediatric. Ileum, most severe, mid, again, we have nothing to do with it. Now, the larger bowel system, ascending, going up, so it goes up, and then it goes transverse. Transverse is what you're gonna see by the liver, right? It's like cutting a pipe. Then it descends, then it goes back, and then the rectum, okay? You guys will actually see, you can see the intestines if your probe goes deep enough. Are we diagnosing though? Anything? Really not. We're not. They're gonna shove them in a CT, okay? Basically, yes.
So you, at the sigmoid colon, the colon goes posterior
Yeah,
towards
it goes
the
posterior and then it goes down.
then inferior.
Yeah.
Okay, correct.
Good to know that because
Yeah.
for ultrasound, eventually, not now, you guys are gonna learn the pelvics.
Yeah.
And when you go up and do a pelvic with the camera in the vaginal canal, you're gonna be able to see some of that. And if it's all gassed out, it's gonna be gassed out. If it's watery, you're gonna basically be able to tell your patient if they need to take a poo or not. Because you're gonna see it all peristaltic. You can also see stones. I've also seen the appendix. And so, because that camera, you can see everything. And so it's good to know where the most important is that transverse colon. Then you've got that rectum with the sigmoid. And then today, what we're going to talk about is the appendix. Pretty much the most important thing. So appendix, small finger-like shaped tube that branches off the first part of the large intestine. The appendix can become inflamed and infected, causing pain in the right lower quadrant. Super important that you know it's not right upper quadrant. If they come into the ER and they have right lower quadrant pain, they're either going to order a pelvic or a limited right lower quadrant, which means we want you to look for the appendix. Now, they have rules. If you're over 25 BMI, then they go straight to CT because we most likely will not find out, we cannot penetrate that deep. So usually it's pediatrics or young adults, right? 20-year-olds, things like that. People with your bodies, right? Yeah. And so we don't do them a whole lot, but there are some places where you get a lot. So it's important to know. We're not going to teach you how to do that today. That's not what today's class is. We're just mentioning it. You guys will actually have a whole section on how to scan for the appendix, and that is definitely not anything in this quarter. So today you're just getting the information, and you'll want to pull this stuff out when it comes to that time. And so the appendix, there's gonna be an iliac vein. This is the cecum. Can you kind of see that? The cecum's right here. So this is gonna be the most proximal end. The reason why I'm saying that is because when you do an appendix, they want to know proximal, mid, and distal. And I had no freaking clue because nobody talked about this with me. So I had to think it through. And now I'm like, as I'm making the slides for you guys, I'm like, that would have helped a lot. So, label this proximal, mid, distal. You can also label here, proximal, mid, distal.
Do we use linear transducer for appendix? Linear?
Yes.
Mm-hmm.
Yes. And you'll learn that
Mm-hmm, mm-hmm.
or the core even after that, I think. Appendix is not easy. I like literally cry every time they try to order one. And I'm like, yeah, so I'm like, they need to go to CT! Yes. So, how do you find it? We're gonna talk location really quick. Again, you're not gonna be tested. I just added this stuff to help you guys pull things together. Things that were missing for me that I needed to help me understand. There's something called the McBurney's point. It's what surgeons use, it's what ultrasound techs use. That is how we find where the appendix is located. McBurney's point, you go from the belly button to the anterior superior iliac spine. So you know the little crest. I want everybody to stand up really quick. Yeah. Stand up.
Yeah. Oh, yeah.
I want you to find the top of that bone. Yeah. And go anterior. So this would be really, this is posterior, right? This is kind of lateral. I want you to go anterior to it. Then I want you to find your belly button. It's gonna be not right in between, but it's gonna be 2/3 of the way. So we broke it into thirds. It's 2/3 down. And so the appendix should be right about here. And that's how you're gonna find it.
Cool.
You're literally just scanning until you find something. And we'll teach you to look for the iliac artery, because it drapes over it. But, as we all say, oh, that's gonna be great and easy. Worst headache in the world. Because, really quick, I'm gonna appendix. No one taught me this, so I put this in here for you guys. You don't have to know this right now. I don't want you to even study it. But there's a lot of different positions the appendix can sit in. And so there are some that it's like 20% of the time you'll find it here. 20% of the time you find it. So the appendix, because it's a finger-like structure, guess what? It's kind of like that gallbladder. You can find it here, there. So that's why it's important that you use the iliac artery and McBurney's point. Kind of look at the region. But don't let that overwhelm you. You don't need to know. That's just to help you in the future. Here's another picture of McBurney's point. So you see how it's 2/3 from the umbilicus to the anterior superior iliac spine. So hopefully that'll help you guys. So ultrasonic signs of acute appendicitis. These are things you will need to know. Non-compressible tubular structure in the right lower quadrant. We already know the right lower quadrant. So they're going to have you compress it. Compressing just means we're pushing on it. What happens if I push on this pen? Is anything going to happen to it? No, because it's hard, right? What if I pushed on this? Oh yeah, it's got my berries in it. Oh, I squish them. That's healthy. That's healthy. And it should should be compressible. If it is not, that means it's sick because it's hard. That means it's got fluid retaining. And you know how when your stomach holds fluid and you're like, oh my God, what's wrong with me? I got all this gas. It's really hard to compress it. And so it needs to be non-compressible. And the wall thickness, over 2 millimeters, and then the overall diameter. So you're gonna measure that wall just like the gallbladder, but with this, you're actually gonna measure the whole thing. And I've got pictures for you.
So the appendix should be compressible.
What?
The
Should be,
appendix.
yes, it should be compressible.
And I'm thinking the patient will be in considerable pain when we're.
Absolutely. Have you guys talked about, what is the,
Murphy's.
Murphy's sign? Oh, it's gonna be worse than that. You're gonna compress, and they're gonna jump out of your bed, and they're gonna curse at you. And they're usually 5 years old. Yes.
I think we need to do it
Yes.
really on the end of the exam, you know.
Yeah.
Exam, and then push and.
It's
Bye.
free fluid in the right lower quadrant sometimes if there's an infection or if it's swollen and it's sick. Thickening of the mesentery, localized tenderness, and presence of calcificated appendicolum. I always say it wrong. Appendicolum. But basically it's just saying stone. They can have stones in them sometimes. And you guys will be able to see it. So that's kind of what we're looking for in a patient with acute appendicitis. So, normal versus abnormal. Here it is, sexy looking thing. Here's your most proximal, mid, distal. We're measuring it. Can you guys see the difference between a healthy one and a sick one?
Uh-huh.
So, again, I wrote it here. The normal size should be 6 millimeters or less. Anything over that, and you're measuring outer to outer wall.
And we'll measure it in transverse.
Yes, A to P. You're also going to measure in SAG as well. But A to P, outer wall to outer wall. Can you guys see it right here?
Mm-hmm.
Can't wait for you guys to have the class where you guys actually have to do it. Have fun. You guys don't say that. Okay, let's look at this one. We measured, and it's 0.845. Is this a sick one or is it healthy? It's sick. It has a thick wall. What is this in there? You guys kind of had to describe that in the gallbladder today. There's some low-level echoes.
Sludge.
So the gallbladder would call it sludge. So just some low-level echoes. So probably an infection. Probably, yeah, an infection. Look at this fluid around it. So sometimes, you're gonna get that free fluid. Now, are these urgent?
Yes.
Yeah, because if it bursts, we're talking septic and we're talking death. So it's a real big deal. Again, this is why I like CT to do them. Kids, though, they're pretty easy.
So are you sure it's not free fluid, or is it, how would you know if it's like ruptured or not?
We wouldn't know. Well, if it was ruptured, we would see it. See how the lining is still intact? But it's definitely just free fluid. The good thing is you just have to describe it, right? The doctor gets to decide if it's erupted. You're gonna have a worksheet, by the way, and you're gonna check yes, no, yes, no, yes, no. And it's gonna be like, is it compressible? Is it this? Is it this? Is it? So they made it pretty easy. So you're really not writing a whole lot. It's all about, are you good enough to find it?
Why do they have free fluid? Is it dangerous or what is it?
Yeah, free fluid's not a good sign. Just like free fluid in the abdomen, that means there's something wrong with the liver or some organ, right? You get ascites in the liver, you get pleural effusion in the lungs is just never a good sign.
Will it leak, like before it ruptures?
You're not, you get the fluid first. Think it would, no, the contents will stay inside of it.
Okay.
Until it bursts. Yeah. Okay. And here's just another picture. Guess what this is inside of it?
Stone.
Yeah, there's your stone. And then when you put color on it, this is like
Vascularity.
right? Very vascular. It shouldn't be this vascular. This means there is
Inf-
definitely
Inflammation.
an infection and inflammation. And then that's scary image. Okay, so what to look for overall in the GI system? Gas. Normal, good, right? Totally. It just will upset you sometimes. And get pretty good. Peristalsis, that good?
Mm-hmm.
And what is peristalsis? You're just gonna see like, and you'll see like gas and light, and it's like, you're gonna be like, what is this? If you haven't already seen it, it's
Discoteca.
kind of
Do you
crazy.
mean when the stuff is just moving?
Yeah, when it's moving, yeah, peristalsis, yeah. It should just have trace vascularity, meaning it shouldn't have like this much vascularity. So trace vascularity. And then shadowing stones is a bad thing, because eventually it'll get stuck somewhere. And then what happens? Then everything backs up. Only go in one or two directions. Thickening prominent wall, very bad. Very, very bad. Rebound tenderness. Bad, bad, bad. Gases within the lumen. Don't think it's a mess. It's just the stomach, right? And then significant stagnant fluid within the lumen. That's pretty bad. You want to see a peristalsis, basically. That's healthy. That's good. That's normal. Any questions? See, this wasn't too much information, right? Yeah. Kind of I just know the basics. Don't know how to, you don't really know how to scan or anything like that. This is really just cross-sectional anatomy so that you guys know where it is, where to find it, and how to find it. So I want to cover her PowerPoint really quick. We're gonna go through it pretty fast though because I integrated most of it in mine. So let me first. And I was working on next week's PowerPoint for you guys. And this guy, his name is Harry Scary. Harry Scary. He's so cute. Okay. Let me pull out. Lecture. So she has 50 some odd pages. Guess what? We're probably only gonna talk about a few of them. I'm gonna go through super fast.
Mm-hmm.
If you have any questions, please stop and let me know. Okay, so she did a biliary review, but guess what? We already did that,
Mm-hmm.
so we don't need to talk about that. This is gallbladder. How can we optimize this image?
Decrease the depth.
Less death. Who's the star of the show? Right now, I'm not sure if it's the liver, or if it's the portal vein, or if it's the gallbladder. Like, who's the star of the show on this?
Gallbladder.
Yeah, gallbladder. So sector within.
Yep.
Bring up that depth. It should be the center of attention, just like you want to be, right? So remember, when you're scanning, center of attention. How can we optimize this guy?
Same.
Depth. Probably chop this off right here as well. Plus, this looks like you just gave a pathology here. You always want to be careful and look at your images before you save or print. Because did you give them pathology that wasn't there? Because sometimes with how physics works, it actually looks like pathology, but it's not really there. So you don't want to get those. Oh, we already did this. Look at all the structures. See?
Mhm.
Done. Okay, spleen. Well, we already already know the location. Where's the location?
Left upper quadrant.
Left upper quadrant. Awesome. Let's see. What is the spleen next to? Where's your touch?
Left kidney,
Left kidney,
stomach,
stomach,
pancreas, tail.
Tail.
diaphragm, pancreatic tail. And what's superior to that diaphragm?
Lung.
Lung. So if we see fluid in the superior aspect, we know it's pleural effusion. If we see it in the inferior, it's
Ascites.
gonna be ascites. Yeah. Don't worry, you'll wrap your head around that eventually. We don't really care to know that it's covered in peritoneum. We just need to know that the hilum is where the vessels come in. You don't even need to know what vessels are posterior or what's anterior. Life is great. What is the shape? You will need to know the shape that shows up on a lot of tests, quizzes, and the boards. Shape is like a mitt, baseball mitt, which is what?
Concave and convex.
Concave and
Convex.
convex. What is the hilum?
The concave aspect.
Good, good, good. And look, we have to go really, really through that. You see? Find that bad boy. And this is another exciting picture. And this is just telling us where it's located. We already talked, you guys already did that. And another exciting picture. Let's just look through one. This is a good one, right? Okay. This is just talking about the red pulp and the white pulp, but literally this is cross-sectional anatomy. Where do you think you learned about the white pulp and red pulp? Yeah, in Rain's class. So I don't really care about it in this class. Why am I overwhelmed? Right? And splenic artery in the vein enter underneath the hylic spleen. She talks about it as the canary of the body. Can anybody explain what that means? Or canary, sorry, yeah, like the bird. Yeah. What is the bird? What does the canary do?
Sings?
Yes.
What
Yes.
does it do?
Yeah, that's exactly. Do you guys all hear her?
No.
Okay, say it out loud,
In
Haley.
the coal mines, they would send a canary down, and if
Ah.
the canary never came back and died, the air wasn't safe to go into the mine. If the canary came back, we could go down the mine.
Ah.
Did everyone hear that? It's like,
You did good.
so the canary, so she likes to, it's like the canary of the body. It's protecting the body, right? It's like a large lymph node, right? It's cleaning and gutting out old blood cells. It works with white blood cells. It is the canary of the body, basically. Yeah. So she talks about it. She's a lot better at explaining it than I am. And it has a fibrous capsule. Okay. Sure. There it is. Very exciting. Oh, another exciting picture. Another exciting picture. The size, without looking, she's got, what is the size that I taught you guys today?
8-13.
8 to 13, exactly. That's what we use. Now the book says 14 centimeters, and but we use 13 now in the clinical world. So that's what Rain's going to use. That's what I'm going to use, and we'll just tell Shay that's what we're using.
Well, like the boards, are they gonna use the book measurement or like?
So the boards, I always stress about that. So I was like, even when I was a student, I was like, there's so many different measurements out there. But the boards are basically, you'll know what the answer is. It's gonna be ridiculous. They're either gonna be like 18 or 6, right? And so you'll know if the best answer is 15, then you go 15, right? If the best answer is 14 or 13. But they're not gonna give you 14 and 13.
Mhm.
They're gonna give you one or the other. So you'll be fine.
Yay.
And I think they gave you. Very important that you guys learn how to do volume. So this one, I want you guys to write volume down. Length times width times height times 0.523. You guys can use this for everything moving forward. Because this have a machine and it messes up, or you mess up the machine, 'cause usually it's, our error, and you come back and you're like, no, it normally calculates it for me. Well, you're gonna have to do this manually on your computer. Okay? So you take the length times the width times the height, and you times that by 0.523. You're gonna use this in physics over and over and over. It's gonna be on your SPI over and over. Oh, and they're gonna trick you. They're gonna say length times width plus height. Or they're gonna go length plus width plus height plus. Don't let them mess you up. It is always going to be length times width times height times 0.532. Oh, and they'll probably trick you and say 0.532.
Ah.
0.523. That was just how whoever was a brainiac figured out the volume for things. But now you can figure out the volume. All you have to go is in your fridge, measure your jug, get the length, the width, and the height, and then you can pretty much tell everybody in your family what the volume of that jug is. And look really smart. Yeah. So
Fridge doesn't
I like
work.
that. Circle that. In fact,
It's square.
do you guys all have a calculator on, or a cell phone, something that we can? Let's practice it really quick. I want to make sure everybody gets the same number. So I'll just give you a typical number.
Mm-hmm.
So, and usually this is going to be in centimeters. So I'm going to use centimeters. So I'm going to say 3 times 1.6 times 2.5, and then use your formula, times that by 0.523. This is a typical ovary size. What is the volume of this ovary?
6.3.
What do we have to say loud?
How many 6.6?
6.2. Perfect. You cut the rest off. 6.2, unless it's over 5, then you
Oh,
round up.
6.3.
6.3.
Yep.
All right. 6.3. And then you're going to write milliliters.
Milliliters.
Because that's what you just calculated it into.
CC.
Why is it milliliters, not centimeters?
I don't know. Ask the math guy.
Oh, it's the same because centimeter cubics it's milliliters.
Yeah.
I thought you were
Cubic
talking
centimeters.
Decimeter cubic it's liter.
And it's also the same as CC, right?
CC.
Yeah.
Milliliters, I know. I'm not.
It's like I grew up with an imperial system my whole life or something, and
Ah.
I trust you more. So.
That's what I learned today. Know that formula inside and out. You guys will use that to measure everything. And now you're a little smarter today. All right, variants. Oh, guess what? We already talked about it. What's the accessory spleen? Where do we find them?
Mesohylum.
Hilum. What is a wandering spleen?
Can be.
Anywhere.
Anywhere.
Usually low.
What is a splenia?
No.
spleen.
No, spleen. What is poly?
Many little
Many. Imaging techniques. Oh, sag and transverse. We already know 2 o'clock and 8 o'clock, and we figure that's not a 90-degree.
180.
180. All right, is that sag or transverse?
Sag.
Sag. It looks like a tree. It's so cute, isn't it?
Yeah.
Yeah. And how about this? Sag, transverse.
Sag.
Oh, let me
Ooh.
ask you this question. There's mass right here. Where would we say it was?
The
Inferior.
inferior aspect. The
This
left
is
lateral.
left lateral up here. This is left medial. This is superior. This is inferior. So it'd be left lateral, inferior, maybe. Yeah. And how could they have optimized this image? Let's change that sector width and chop this off. Because then it would be a true inferior, right? Right now you're giving me too
Mhm.
much. So how about down here?
Superior left medial.
Medial. Got it. Left medial. See how much you learned today? go, transverse versus sag. Oh my gosh, is this a mass?
No,
Are these masses?
maybe, probably not.
Are they cysts?
Color.
Color, that'll tell you what it is. I don't know. Let's put some color on it. Probably just vascular. This is what it looks like on a CT. This is an enlarged spleen. It should not look the same size as the liver. Definitely enlarged. Here's a kidney. Clearly, this kidney. Wow, kidney. What? So we're further down now. You see
Yep.
the pancreas? Liver, gallbladder, right kidney, left kidney, tiny little spleen. Question, do they really have a spleen? It's so small. But this is what normally it looks like. It's not gonna be large in the chart. There's another view, here's your liver, this is your spleen right here. Tail of the pancreas is right here. Woo! Is that a healthy spleen?
No.
I mean, it's healthy, it's hearty. Too big. Too big. GI. Oh, alright. We know it starts at the mouth, the esophagus, and ends where?
Cardiac sphincter.
Right.
G junction, LS, cardiac sphincter, whatever you wanna call it. And where are we gonna see this on ultrasound? The esophagus, there's two places.
Thyroid.
Thyroid, it's gonna be on what side?
The left
Left.
The left.
posterior.
Left posterior medial. And then the sphincter, no big deal, but we will see that.
Sagittal, proximal aorta.
The proximal aspect of a sag aorta image. You'll see the left lobe of the liver. You'll see this round thing that you're gonna get confused and think, oh my god, there's a mass. But it's not. Okay. And then you've got the stomach, and the stomach starts basically at the pyloric sphincter, and starts at the cardiac sphincter, ends at the pyloric. Do you guys need to know any of that? No, only
But
if
this
work with
body,
needs, and then you have to worry about, helping them figure out. Small bowel, large bowel, where, are we gonna see the small bowel?
Not
No.
really.
No, how about the large bowel?
Yeah.
Yeah, we're gonna see the large bowel in certain instances. Where is the appendix? Is it in the large or the small bowel?
Large.
Large, beginning of the large. And it hangs off the cecum. Where is McBurney's point?
2/3
from
from
the
your
belly
belly
button.
to the
Anterior,
Anterior,
superior, spina.
Yes.
Yes. Does anyone want to briefly come up and show us? Tommy, I haven't picked on you in a while.
yeah.
Tommy, come show us.
She's sleeping.
Make sure he's engaged in outer space. Are you okay showing your stomach off? Okay, then you don't have to, you can keep your jacket, on. So McBurney's point, where's the first place? That's the umbilicus. Yeah, McBurney's point is that, because his umbilicus, are you okay with me touching him? So, where is that, right here? Alright, good.
That's my
And
belly
then-
button.
And then that's the crest of that, and then, yeah, if I went halfway, it's here, but it's a little further, so it's gonna be further down, right? 2/3 further down, Okay, another fun picture. Esophagus, do we really care? We don't really care about all these details, just so you know. Cool. ESO, look at that, that's your esophageal. Another hand can call it. You guys don't
The
really.
EG junction.
Here's your EG junction. You'll need to know that. It's gonna show up on your board, it's gonna show up on your test. And the thyroid, you're gonna have to know that's on the left, medial, posterior side of the thyroid, esophagus. Stomach. What's this?
Gas.
Gas. What's this guy?
Pork my confluence to split.
Handsome little thing. That is the
Oh, pancreas.
And the tail goes way down here. And then you can see the kidney, which we're gonna talk about next week. And what a long left lobe that is right there. That's left lobe and a little bit of the right lobe. Oh my gosh, I wonder what this ligament is. Do you think Bree could tell us what this ligament is?
Round one.
I'm gonna help her and save her. It is the teres, ligamentum teres. Is this Italian?
Yes.
Okay. Small bowel. Here's her picture. She had us draw this picture just so we had a concept and understood the sphincters and like how things go. So what I'm gonna have you guys do is just draw this really quick. And label it. Hey, we're already on slide 39 and we're only 50.
Is it just
This is
Duo-
just this is the
Duodenum.
esophagus,
Duodenum,
and then
yeah.
small
So this is 4
intestine.
seconds.
yeah? Because I thought, is it colon?
No.
Just duodenum. Okay, got it. Mm-hmm.
Oh, and it does have a large intestine. It's kind of a combo. I don't remember why she had us draw this, to be honest. So, just have to get draw because she had us draw it, okay?
Descendant. Ascendant. Transverse. Boop. Is it boop? Boop.
Bulb, yeah, I don't know why that's called bulb.
Boop, it's like onion boop.
Oh, yeah?
Yeah, it's really good to just know where it twists and turns and how it is, and so when you draw it out, it kind of helps you like put perspective on the loops. I have to have a day where all the people in the back come to the front.
I guess I'm a little confused. Compare this to
Yeah.
this.
So she's skipping a few things.
Yeah, because that's the ascending there.
It's colon and
That's
the
colon
picture
and that
about
picture is-
duodenum.
What's that now?
So this is the duodenum. This is still small intestine.
Oh, okay.
Just
Yeah, and
first
then
part
she's
of-
just showing how it goes this way.
Oh, gotcha.
So this is the small intestine, you guys, not the large. She just wants you guys to know how it curves in the body. I've never had to use it, but it's nice to know if I did need to know this. It's really hard to find a picture that actually depicts what the small intestine is. So the fold is kind of how it kind of goes up and then goes down. The bar extends. Is it fold or bulb? Oh, bulb, the bulb one. Yeah, that's your duodenum, basically. And that is where the sphincter is going to be. I wish I could remember you guys. Lecture was like 2 years ago. I don't know. Just tell her I did a great job.
First I thought it's colon too, and then I thought no,
I was
no,
like,
it's
yeah, sure,
opposite.
no
It's
problem. Just send
ascendant,
me your
descendant,
lecture.
and then I
Yeah,
realized it
last night I
duodenum,
was like,
duodenum.
Alright, so there you have it. Yeah, it's torturous. I'll tell you something you didn't already know. There it is again, torturous little sucker. Large bowel, we pretty much already know. We already talked about that. Ultrasound, we already talked about all of this. And there's another picture. We talked about this too. And normal bowel, right here. Yeah,
Invagination?
Basically, what it means is not a good thing. That means that it has looped and looped on itself and folded and folded. You know, like those captains in the back in the Caribbean days, right? Maybe the Caribbean. Let's go with that. And where they go to look. That's what happens when it goes like goes back. That's what happens to the intestines for children. It's called I can't even write it in.
Invagination.
Intestination.
Invagination.
If you don't work with
Vagination.
pediatrics, you're not gonna need to know this, but she did put this on here, so she's probably you'll need to know what it is. If she was to give this to you on a test, you'd have to say bullseye or target, and it means intussusception. And it just means that the intestines are folding, and it's very painful. Kids cry and have like the stomach pain, right? And it's so sad, but they can fix it. It's just groups of bowel like that are gone wrong.
Called?
What?
Called?
Intussusception.
Invagination.
Invagination?
Yep.
So that's not what you said.
Yeah, here it is.
So you're saying two different things.
Here's how you spell it. Condition which part of the intestine slides into an adjacent part of the intestine.
Intestination.
Oh, they call it differently? Cool.
Oh yeah, is that too small? Oh, so sorry guys. INTUSSEPTION.
Let me see,
So
maybe.
it's just like folding on itself.
How wide is it doing this?
Baby Jesus made it that way. It just happens sometimes.
Is it really common? That's very rare.
It's very rare. Thanks, you. I was gonna say, I mean, I've only seen it happen once in a pediatric setting. Again,
Yeah,
it's a
it's,
pediatric
you call
setting,
it
so I
differently,
don't
but
want you
it's
to
Latin
strain
name.
your brain.
So
Just know
interesting.
what it is called.
Probably has several names.
Maybe, yeah.
Then,
Mm-hmm.
this is what we call keyboard
Interesting.
sign. This will show it more in your brains class, and we'll hear, because this is cross-sectional anatomy, right? But this, she will talk about what does that mean. Keyboard signs are not good. There's something wrong with the intestines. And you can see it's stagnant, there's nothing peristaltic. I mean, you have to see it live, I'm just telling you live what it's telling you live. But all of these little things, these are the little villi in the intestine. You should not be able to see those. Yeah. So this is ultrasound. Well, we can see this. So this is one of the only things that we can really see. And this is one of the large intestines. And you shouldn't see that. I've only seen it once in my short career. And I felt really smart because I described it as the keyboard sign. And that's it. I didn't have to say what it was, what it did. I left that to the rad. Okay, what's the shape and location of the spleen? We already did that. What scan windows do we use to evaluate the spleen?
Intercostal versus
Right? What can abnormal bowel look like?
target sign.
There you go.
Keyboard sign.
Congratulations. You just did lecture on lab and it wasn't too bad though, was it?
No. Okay.
In fact, it only took us 2 hours. To be honest, because we were, because I gave you guys more time for the test. Do you guys want to? You guys want me to show you how to do a spleen movement, or are you guys done?
Show us tomorrow.
Yeah.